don't need to introduce my very good friend, Dr. Khadija Hafid. Everybody knows her. An academic in MBRU and Dubai College, and a senior diabetologist in Dubai Health for many years.
Thank you very much. Get hooked up. I think I'll just, is there a clipper? No, how do I clip this on? Because I don't have a pocket. Anyway, so Assalamu alaikum everybody. I don't know, can you hear me? I'm delighted to be here this morning, and it was a great privilege to be part of the cardiometabolic guidelines spearheaded by Dr. Mohammed Hassanein and Hani Sabur. We had a lot of fun, a lot of arguments, but in the end, I think we came up with a document that's really going to be helpful for all of us in the long run. I have two disclaimers. The first one is that it's a challenge to speak after Professor Hassanein. His energy, mashallah, is really unmatched. This is his third road show he's been doing. He had one on Friday, yesterday as well, and you can see the enthusiasm this morning as well. The second disclaimer is that there's going to be a lot of slides that have been repeated, and that is also quite deliberate, because repetition is there for reinforcement. The aim is really to make the guidelines a chorus. You know, you have a song, you may not remember all the words, but the chorus is going to be the same. So all of us are going to be singing the same chorus. Right, so the patient that I'm going to be discussing is a 47-year-old male who's come to clinic because he's got hypertension. And so let me introduce, before I introduce you, we're going to do the same sort of voting system. So if you haven't yet scanned your QR code, please do so, because the questions, you'll be answering through the same platform. All right, so let me introduce you to the patient. He is 47 years old. He's a hotel manager, so you can imagine how much sleep he gets. He's been hypertensive for the last 2 years. He's got diabetes for a year. He's not had any sort of major events, no history of hospitalization recently. He's a hotel manager, doesn't have time, works very long shifts, so he doesn't have any chance to exercise. And as you can imagine, like all the people who work in the F&B industry, he's a heavy smoker. All right, so any questions about that? Okay, we've got some brief information about Yusuf. And so we go on and we look at what medications he's on now. He's on an ACE inhibitor, and he's taking metformin 500 milligrams once a day. And his initial blood pressure before he started treatment was 170 by 95. And at home, a week before he went to see his GP, it was 160 by 88, right? And the reason that he's actually come to the clinic is because he's worried about the high blood pressure reading. And on top of that, he thinks that the frequent headaches that he's getting might be related to his high blood pressure. So you go ahead and examine him. His BMI is 27, so he's clearly overweight. His blood pressure in clinic is 159 by 90. He's got a pulse of 73. And you're a good physician. You've done his pedal pulses, and there was normal pulsation. Are we good so far? Right? Okay. So we carry on and look at his cardiac and chest examination, and nothing remarkable there. Jugular venous pressure is fine. He doesn't have any added sounds. So based on his clinical profile, should we be screening him for cardiometabolic disease? All right, great, so I can go home. We're already singing the chorus, I can see that. Okay, so let's move on and discuss. Now, you've already seen this, and we've emphasized the fact that the people who have any form of dysglycemia, prediabetes, type 2 diabetes, and we've already dwelled on the patient with type 1 diabetes above the age of 10, but of course, if they're older, you might need to do it a little bit earlier. So this is, again, part of that chorus. How to screen has also been very, very elegantly and very detailed already. So we're going to do all these things for Yusuf. The only thing here I would add is, if it was not Yusuf, if it was back to Noura, about the symptoms at the perimenopause, so women around 49, 50 and all that, they may not also complain so much of the chest pain and shortness of breath. They may be having other symptoms, which they may then, you know, when they go to their gynecologist, they say, oh, it's part of your perimenopause or part of your menopause. That's incorrect. And we know that many times women get their diagnosis of coronary artery disease late, and they present late to hospital and have worse outcomes because we downplay their symptoms. So please make sure that, you know, if she is complaining and she has shortness of breath, we take that seriously, and it's not menopausal symptoms. Right, so again, let's see what we're going to do for Yusuf. So you're in clinic. Which of these investigations would you want to send out for him? And I don't know if we have a possibility of doing multiple. No, is it multiple? Yeah, okay, great. So I'll give you a few minutes to put in your answers. All right. Okay, the potassium level, so we've missed that, right? Is it not? Okay, it's there, okay. Right, and we've got lipids, A1C. Good, 100%. Easy stuff for Dr. Hani. Yeah, and as we said, you know, earlier, we'll need to do all these tests. Okay, good. ECG, proBNP. All right, so remember, he came in with a routine visit. I'm not happy about my blood pressure. I've got frequent headaches, but he does have underlying diabetes. All right, great. I think we can move on. Okay, so traditionally, as was mentioned earlier, we just did the foot exam. Retinopathy was part of the annual screening for people with diabetes. But now, with the emphasis is really to add the cardiac biomarkers. So the NT-proBNP is an essential test that needs to be added to the examination profile, and then to make sure that we also do the ankle brachial index. The coronary calcium score, if there's a possibility, might also add value in trying to categorize the risk for your patient as well. It's not mandatory, but it is there in the guideline. Right, so I think most of you had already picked up all the investigations that are required for this gentleman, and these are his laboratory findings. So he's got a hemoglobin A1C of 6.4. Remember, he was only on metformin, 500 milligrams once a day. His fasting blood glucose is 125. His urine albumin to creatinine ratio is 70 milligrams per gram, so that's abnormal. He's got a total cholesterol of 190, his LDL is 130, and his triglycerides are 280. Okay, right. Any comments? Right, there's lots of things that need to be done other than just his blood pressure management. Okay, so that was his ECG, because that was a part of the investigations that we required. So sinus rhythm without any significant chamber enlargement, and there aren't any specific STT or T-wave changes. So why did we say we needed to screen all the other things? Is because diabetes is related or associated with the other complications. They're at a higher risk for developing atherosclerotic cardiovascular disease, heart failure, atrial fibrillation, and renal impairment. And as we've seen, with our patient, he's already got evidence of albuminuria. So moving on as well, you're all aware of the fact that hypertension is also associated with a very high burden of cardiovascular disease, and it is associated with development of coronary artery disease, cerebrovascular disease, both in the form of ischemic strokes and hemorrhagic strokes. That's what keeps me busy in the hospital as well. And it is also associated with development of chronic kidney disease. And so we would like to be able to prevent all these complications. So the other factors are obviously very important in looking at in people with hypertension is listed here, and I'm not going to read all of them. It's quite an exhaustive list, but again, the sedentary lifestyle that was already alluded to earlier, obesity, diabetes, Lp(a) becoming more and more trendy now, and we're getting more information around that. And of course, the psychosocial and socioeconomic status are just as important. We've heard about the importance of sleep and smoking, right? So smoking cessation, counseling is extremely important. In every single visit that the patient comes to, we ask about whether they smoke or not, and whether they've started their journey on trying to cut back on smoking. Right, so I think that's the next question. So based on what we've so far seen about Yusuf, we now need to categorize his cardiovascular risk. And I'll give you a moment to do that. Right, so he had high blood pressure, he had dyslipidemia, he has, what else? He has diabetes, right? Okay. He has albuminuria, okay? Okay, great. All right, a few more. Has everyone voted? High, very high. Okay, I can see where. All right, so let's see. Right, so he is at very high risk because he's already got end organ damage. We saw that he's got albuminuria, he's got diabetes, although, so if somebody already has end organ damage, he already fits into the high, very high category risk, and then you don't really need to do this. That's for individuals who test negative, whereas he's already, in one of the tests that we've done, we've already identified that he's got evidence of end organ damage. So we need to now concentrate on how we're going to change the trajectory of his outcomes for the future. Right. So high-risk conditions demand blood pressure control, and I don't know whether you can see it from there, but this is the 2024 ESC guidelines that Zinat had already talked about. And then the sort of highlight from this year's guidance is that we need to, treat to levels that are less than 120 by 80 millimeters of mercury for the majority of people. For diabetes, it still remained at 130 by 80. And for our patient, Yusuf, remember, his readings were still like 30 millimeters above target. So we're going to discuss on what we should do with him. So again, here, this is, of course, a European guidance. So they are using the SCORE risk calculator. But nonetheless, what's important to remember is that you need to get the blood pressure targets to a lower level, because we know that actually improves the outcomes in terms of the heart, the brain, and the kidneys. Okay, so let's see what you think Yusuf's blood pressure target should be. Less than 120 by 80, less than 130 by 80. Are you happy with 120 by 70? Okay. Any more? Okay, 75-25, so almost everybody has voted. Right, okay, great. So these were the 2024 ESC guidelines, and they've now sort of put in 3 categories. Just go through them very quickly. For non-elevated blood pressure, and they're using 3 different modes of checking the blood pressure, either using office blood pressure readings, home monitoring, or ambulatory blood pressure monitoring. And for elevated blood pressure in the office, anything between 120 to 139. If you're using home measuring a device, then it's 120 to 134. And if you're using the ambulatory one, the readings are also lower. So what do they recommend? To risk stratify in order to identify these individuals with a high cardiovascular risk in order to initiate pharmacological blood pressure treatment. And then on the other column, the patients that have hypertension is if they've got an office blood pressure reading that's above 140, if you're using the home monitoring machines above 135, and likewise for the ambulatory devices. And here the cardiovascular risk is sufficiently high to merit blood pressure pharmacological treatment initiation, and we'll discuss that in a minute. So what is important, of course, is to make sure that we address this, and I think that is usually not discussed enough when we're in clinic. You have the 20 minutes, and probably we concentrate so much on the pharmacotherapy. You have your antihypertensives, the antiglycemics, the lipid lowering, and we actually forget about talking about lifestyle and emphasizing on that to our patients. So making sure that they're reducing their dietary sodium, because that's really essential. If you are increasing your medications and the patient carries on taking as much salt as he wants, the medication is not going to be working. Increasing dietary potassium intake might also help, and of course increasing physical activity is known to also help in reducing blood pressure. So we want to aim and have a blood pressure target that's less than 130 by 80, less than 120 by 80 if we can, without the patient having any symptoms. And again, the emphasis about individualizing the blood pressure targets, taking into consideration the cardiovascular risk, any potential drug side effects, and the patient's preference, of course. Because if Yusuf was slightly older, maybe in his 70s, you might not want to get him to as low as 120 over 80 if he's having any evidence of postural hypertension. Okay, now the other thing is to note that if someone's blood pressure in clinic is greater than 160 by 100, they should ideally be on dual antihypertensive therapy, because with monotherapy, you're not going to be able to reach the desired blood pressure targets, and it also helps with compliance. It also helps when you start with a dual therapy, the patient doesn't really feel that, okay, it's my fault, my blood pressure is not getting control because it's my fault, or my disease is getting worse. So if you start with monotherapy and then let them come after 3 months and you're going to add on something else, and go, so does that mean that my condition is getting worse? Whereas if you start them off with dual therapy and can get them to those blood pressure targets early, the patient doesn't feel as bad. Right, so this is the ASCVD risk reduction algorithm for hypertension, and I'll just quickly walk you through it. It is a busy slide. So the goal is to have a blood pressure target of less than 130 by 80. Lifestyle intervention, again, is emphasized as, every single time that the patient comes into the clinic. Use of RAS inhibitors, either an ARB or an ACE inhibitor. And if the blood pressure reading is above 150 by 100, then start with dual therapy at the get-go. And then titrate the medication every 2 to 3 months, not every 6 months to a year. So that patient should be coming in back to clinic early for you to titrate. If they're not at goal, then we can add a thiazide or calcium channel blocker. And then, you know, what can go on after that is a combined alpha, a beta selective blocker, or an MRA. And so what would be the next step for Yusuf? We've identified that he's a very high risk. His blood pressure is 30 millimeters off his target. What should we do with Yusuf? Should we send him to Dr. Sabur? Should we encourage lifestyle modifications? Should we increase the dose of his antihypertensive? Maybe replace his current medication? Do we start him on an SGLT2? Lots of things to choose. Dr. Zahani's clinic is booked for the next 6 months, so you're going to have to do everything yourself.
We're available by phone and WhatsApp.
Okay. Okay, lifestyle, important. We're going to, so no one wants to tackle his diabetes. Huh? His A1C was 6.4, he's very high risk. I don't, huh? It doesn't allow you to do multiple things, right? Okay, right, so discussion. Again, back to the chorus. We need to do everything in tandem, right? So lifestyle modification, we've already talked about that. Blood pressure control, we want to get him to below 130 by 80. And that's all the guidelines, the same. Whether you're in the European side, you're across the Atlantic, ADA, ACC, they all say the same thing. Intensive management of dyslipidemia, that will be discussed in the next case. Antiplatelet therapy, and of course, making sure that we get him to his glycemic target. A1C was 6.4. So, he was on an ACE inhibitor. He was on lisinopril, if you recall. But his blood pressure is 150 by 90, so he will need to have additional therapy. So the addition of a calcium channel blocker or a thiazide-like diuretic would be important. And then if that isn't working, an MRA could be considered. In those patients who also have evidence of sympathetic overdrive, the use of selective beta blockers might be an added benefit for those patients. Right, back to this busy slide again. Now, we've agreed that Yusuf is in the high-risk category, and therefore, for his glycemic control, and for the fact that he's got albuminuria, right? He's got end organ damage, an SGLT2 inhibitor would change his trajectory. Blood pressure target, we've already said less than 130 by 80. We would also want to have his LDL less than 55, and antiplatelets would also be indicated in his case, right? All agree? Any difference in the management? Yeah, okay. So going back again to the European Society of Hypertension guidelines, blood pressure lowering should be prioritized. And, you know, we've already talked about which 3 agents we would give this gentleman, and it's available as a triple combination, so an ACE inhibitor with a calcium channel blocker and a thiazide-like diuretic. Right, so combination treatment, of course, is helpful. It improves the compliance, and it can get the patients to their blood pressure targets as early as possible. All right, and then again, this is just the stepwise approach. I'm not going to dwell too much on that. I'm sure all of you have seen this slide many times before. So going back to his new treatment, we've added the SGLT2 inhibitor because he had evidence of albuminuria. We've given him the triple combination because we want him to get to that blood pressure target of less than 130 by 80. And we're going to emphasize on the lifestyle modification, salt restriction, physical exercise, and I should have added there as well, smoking cessation. Right. Thank you all for your attention and questions. Controversies. Anybody with a different plan, or are we all singing the same chorus?
So it might be interesting how we spoke to a patient who's had a previously higher target, and now we're telling them you need more medication.
Right, okay.
How do you manage that discussion?
Yep, that is a very good point. And the best way is actually to talk about his risk. So patients also know that, yeah? And you tell him you're at a very high risk. He's got already evidence of albuminuria. So he, instead of saying to him, all right, we are going to just manage your hypertension, we want to make sure that we can give you something that is also going to protect your kidneys. And we have good evidence that the SGLT2 inhibitors have shown evidence that they can do that. So you can add that onto his metformin, or you can replace his metformin if you think that it might lower his blood sugar too much. His A1C was at 6.4. The metformin is not going to change much in his kidney function, but at least the SGLT2 inhibitor is going to address his glycemia and help to reduce the albuminuria as well, right? Blood pressure, very important. Again, he's at high cardiovascular risk, he's at risk of MI, he's young, he's only 47. But for him as well, this particular patient, the smoking cessation is the most important thing. I'll leave the lipids, for you, but if the patient understands the cardiovascular risk, then it becomes easier to address all those things together. If you feel that the patient is a little bit hesitant, you might want to bring him to the clinic a bit earlier. So if he comes in and at least the blood pressure has come down, because his primary concern when he came in is, I'm getting frequent headaches and my blood pressure is too high. So you've given him the triple therapy. He's now reassured that my blood pressure has come back. Maybe his symptoms have improved. Then you can, talk about, look, we can do even better and make sure that, now we tackle the lipids as well. So, it's always good to, make sure that patients also understand their cardiovascular risk, and then that can improve their compliance. Right.
I think this is really important, for the group that, when you're doing this calculation for yourself, but it's very important to share it with the patient.
Yeah.
Because you're adding more medication, doctor, I don't want more pills. You have a high risk. How do you know it's high risk? So this discussion is very important. This is something they will get out of it. What does the patient want out of this equation? They want to remain healthy and not have complications. So I think that's the way you motivate them. Because you're going to have a lot of pushback, and you see a lot of times with the farmers, patients refuse.
And that's the beauty of having the combination pill, because at least it's not increasing the pill burden, right? Yeah. Maybe in the future we'll add the SGLT2 to the antihypertensive.
And the statin and the aspirin.
And the statin and the aspirin. So we have the polypill, yeah, the famous polypill. Okay, if there are no questions, I think we can move on. Oh, we have a break. Yeah, excellent. We do deserve a break. So there's coffee outside, 15 minutes?